So, for case presentation, a 40-year-old female was diagnosed to have a 6 by 5 by 4 centimeter right ovarian mass by ultrasound. Oophorecystectomy was done and the mass was submitted to the laboratory for his histopathologic examination. So, for etiology of the disease, it accounts for 20 to 25% of ovarian neoplasms. It occurs mainly in middle adult life, rare before puberty and after menopause. Most are benign or borderline. Primary mucinous carcinomas are rare, only 3% of ovarian cancers. For possible origins, mucinous glands of teratomas or Brenner tumors, and Mullerian epithelium with mucinous differentiation. So, to differentiate it from adenoma, an adenoma is a benign epithelial tumor characterized by the proliferation of well-differentiated glandular structures, usually presenting as a solid or polypoid mass, whereas a cyst adenoma is a benign epithelial tumor that grows in a cystic pattern, forming large unilocular or multilocular cavities lined by epithelium and filled with fluids, either serous or mucinous. For the pathogenesis of ovarian mucinous tumors, um, normal ovarian surface epithelium, so the ovary is covered by a simple cuboidal epithelium derived from the Mullerian ducts. So the epithelium is normally not mucin secreting. Mucinous tumors arise when this epithelium undergoes metaplasia into mucin secreting columnar cells. Other possible sources are Brenner tumor epithelium, transitional cells that undergo mucinous change, or teratomatous mucinous glands. So next is mucinous differentiation. So through metaplasia, cells acquired features of intestinal or endocervical type epithelium such as tall columnar cells with basal nuclei and mucin-filled apical cytoplasm. So these cells begin to form cyst filled with gelatinous mucin-rich fluid. Then the genetic driver mutation, which is the CRAS. So CRAS mutation is the hallmark initiating event. So it presents in 58% of benign cyst adenomas, increased to 75 to 86% in borderline tumors, and found in 85% of mucinous carcinomas. So CRAS activation is a constant proliferative signaling pathway which leads to uncontrolled growth of mucin-secreting cells. This explains why KRAS mutation is present in early and persists throughout the progression. Then next is tumor development spectrum. So with the additional genetic or epigenetic alteration, tumors evolve along a continuum. So first is benign mucinous cyst adenoma, which is a single layer of mucinous epithelium, no atypia, no invasion. Next is borderline mucinous tumor, epithelial stratification, tufting, papillary architecture, mild atypia but no stromal invasion. So mucinous carcinoma has two types, the expansile type, which confluent glandular growth that compresses stroma, and the infiltrative or desmoplastic type, which is a mucinous cell infiltrate the ovarian stroma with fibrous reaction, which is more aggressive. So for the gross morphology of the disease, usually it is large, multiloculated cystic masses. Some are greater than 25 kilograms. It contains sticky, gelatinous glycoprotein-rich fluids, unilateral in most cases, and only 5% bilateral. So surface involvement is uncommon. So the left photo is a mucinous cyst adenoma. Note the multicystic appearance, the delicate septa, and the presence of glistening mucin within the cyst. The right photo is a view at laparotomy revealing massive overgrowth of a gelatinous metastatic tumor. And for microscopic morphology of the disease, it is benign tumor in the ovary. So as we can see in the picture, it is lined by tall columnar mucin-rich cells without cilia, usually gastric or intestinal type differentiation, and rarely lang yung endocervical type. So the cyst wall, as I said earlier, is lined by tall columnar cells, epithelial cells with basally located and abundant apical mucin vacuoles. So the mucinous cyst adenoma can be differentiated with serous cyst adenoma. Si serous cyst adenoma is usually smaller siya than mucinous tumors and unilocular siya, and yung cyst niya is filled with clear watery serous fluid, while si mucinous cyst adenoma is multiloculated and yung cyst niya is filled with thick gelatinous mucin-rich fluid. So the left upper photo is a columnar cells lining the cyst, and the right upper photo naman is the histology of peritoneal implants from an appendiceal tumor showing mucin-producing epithelium and free mucin. Yun yung tinuturo ng arrow. So for clinical features, manifestation is often asymptomatic until large. So early on, the tumor is usually small and confined to the ovary. So the ovary is located deep in the pelvis with room to expand. So the growth is often asymptomatic until become quite large. Then it present abdominal distension and palpable mass. So mucinous tumors produce a lot of mucin, filling the cystic spaces with thick gelatinous materials. This makes the tumor very bulky, often greater than 20 centimeter. So as the mass grows, it causes visible abdominal enlargement or distension, and a palpable mass can be felt on exam.
Hello, my name is Joanna Paula Pineda, and we will be talking about lipoma in the subcutaneous tissue. And so, before we begin to discuss it, this is just a brief outline of what's to be expected to be discussed today. We have the etiology, the pathophysiology, the morphology, as well as the clinical significance. And here we have a short description of lipoma. It is a type of benign soft tissue tumor. It is characterized by mature white adipose tissue thought to arise from pluripotent mesenchymal stem cells. It's important to know that lipoma or the development of lipoma is usually sporadic, which means that there is no known predisposing or causative factor when it comes to its development. However, there are several factors that are known or that are theorized to contribute to its development in certain individuals. We have genetic factors such as chromosomal rearrangement 12q1315 affecting the HMGA2 gene, which is a transcriptional regulator, and a small minority are also associated with germline mutations in tumor suppressor genes that are associated with well-described syndromes such as neurofibromatosis 1, Gardner syndrome, Lee-Fraumeni syndrome, Osler-Weber-Rendu syndrome. Aside from this, others are known to be linked to environmental exposures and trauma, particularly radiation burns or toxins. The development of true neoplasms of adipocytes is usually linked to metabolic disorders or abnormalities and in obesity as well. Now let's talk about the morphology. We have both the gross and the microscopic findings, and we will be showing pictures later to highlight these specific findings. But now let's talk about the description. It appears as a soft, well-circumscribed yellow lobulated mass, often encapsulated and resembling normal adipose tissue. It usually arises in the subchitis of the proximal extremities and trunk during middle adulthood, and infrequently or rarely, lipomas are large, intramuscular, and poorly circumscribed. So just based on this, we can deduce that lipomas are generally smaller in size, usually 2 to 5 centimeters. There are, however, giant lipomas that are that could reach up to 10 centimeters in size. Microscopically, the important characteristic findings are the following. We have the fibrous capsule with aggregates of mature fat cells and congested blood vessels. Let's look at the gross morphology. As what was mentioned earlier, you can see that it resembles normal adipose tissue. It's yellow, right? Fat is usually yellow. It's well encapsulated as what is seen in the outer capsule of this certain lipoma. And microscopically, the three important features are the fibrous capsule, the aggregates of mature fat cells, and congested blood vessels. So, as you can see, the exact development or microscopically, you could really appreciate the adipose fat, the aggregates of mature fat cells in this slide. Next, let's talk about the pathophysiology of lipoma, how it develops. And so, as it was mentioned earlier, it is usually thought to arise from mesenchymal stem cells. And in these mesenchymal stem cells, whenever or if a chromosomal rearrangement is present, particularly in 12q13.15 HMGA2 gene activation, there is the uncontrolled proliferation of adipocyte precursors. And because of this, there is the formation of your mature adipocytes, which we've seen earlier. And it's eventually encapsulated by a thin fibrous capsule. So your mature fat cells are developed first because of the uncontrolled proliferation, and eventually it is encapsulated by a thin fibrous capsule. And again, as what was described earlier, eventually a slow growing, well circumscribed, benign tumor known as your lipoma eventually develops. And let's also talk about the clinical manifestations. And because lipoma is generally benign, it's generally or usually asymptomatic, and most are discovered incidentally. So it's not because of pain or anything like that, although that could exist as well. Most of them are just randomly discovered. And so, common sites are in the trunk, neck, shoulder, back, and upper extremities, particularly in the forearm. And when you palpate the lipoma or the soft tissue tumor, you'd actually find that it's freely movable under the skin and it's not usually fixed to deeper structures. I've mentioned this earlier, but let's just talk about it again. The size is usually 2 to 5 centimeters, but there are existing giant lipomas that can exceed 10 centimeters. And again, symptoms are not common. It's usually asymptomatic, but if pain is present, it's actually usually because of compressed nerves, or if it's a type of angiolipoma, which is more vascular. And it could possibly restrict movement if it's large or if it's near the joints. And usually, people who get the lipomas removed, this is actually because of cosmetic deformity or for aesthetic purposes, because um, like what I said earlier, usually it's asymptomatic and really doesn't do much. So usually its excision is linked with cosmetic deformity. And finally, there are special presentations, particularly in multiple lipomas. This is seen in familial multiple lipomatosis or syndromes, like in Madelung's disease and Cowden syndrome. And deep-seated lipomas, those that are found intramuscularly and retroperitoneally, may cause pressure effects on nearby organs. That's it for today. Basically, we talked about lipoma. We now know that it's a benign soft tissue tumor. It develops as a result of an uncontrolled proliferation of fat cells, and eventually surrounded by a fibrous capsule, and eventually affects or eventually leads to congested blood vessels as well, because the fat has already, um, you know, uncontrollably proliferated in the subcutaneous tissue. So that's basically it for today. Thank you so much for taking the time to listen to my report, and have a good day po.
Good day, everyone. I am Bernadette Abigail Quintero, and I will be reporting about leiomyoma of the uterus. So this report will follow the flow of first its etiology, next is pathogenesis, morphology, gross and microscopic, clinical features, and the treatment. But before we proceed, we have to know what is leiomyoma. So, this is the most common tumor in women, which affects around 30 to 50% of women of the reproductive age. They are benign smooth muscle neoplasms that can appear as a single mass, but more often they occur in multiples. Ayan, yung picture sa side, yan yung itsura ng leiomyoma in gross morphology. And then next is its etiology. Their development is linked to the genetic abnormalities, and about 40% show chromosomal changes, particularly in genes like HMGIC, HMGIY, and MED12. Also, they are strongly influenced by hormones, especially estrogen and progesterone, which explains why they are more common in the reproductive age of women. And they are also more common in Black women. And then for its pathogenesis, the flow is genetic alterations and then hormonal influence, followed by cell proliferation, angiogenesis, and then uterine distortion. So we begin with the genetic alteration since around 40% of leiomyomas show chromosomal abnormalities, and their common rearrangements include those affecting with 12q14 and 6p, which involves the HMGIC and HMGIY genes. The MED12 gene mutations, found in about 70% of cases, plays a major role by disrupting normal cell signaling and growth regulation. And these mutations make certain smooth muscle cells in the uterus more prone to uncontrolled growth. And then for the hormonal influence, estrogen and progesterone strongly stimulate leiomyoma growth. Since estrogen increases the expression of growth factors like epidermal growth factor, insulin like growth factor, and transforming growth factor beta. And then progesterone enhances proliferation by upregulating anti apoptotic proteins like BCL2 and increases extracellular matrix production. And this is why fibroids grow during reproductive years and shrink after menopause. Again, fibroids are the other term for leiomyoma. And then cell proliferation. This is mutated smooth muscle cells that divide more than normal. So, nagkakaroon din sila ng increase in size. And then angiogenesis. The growth factors stimulate the formation of new blood vessels that feed the tumor. And this increased blood supply supports the continuous growth of the fibroid. For the uterine distortion, and as the leiomyomas enlarge, they change the shape and structure of the uterus. So it depends on the location. It's either submucosal, intramural, or subserosal. And this distortion can also cause bleeding, pain, and even infertility in the worst cases. So here we have the gross morphology of the leiomyoma. So they are well circumscribed, round, firm, gray-white nodules, and their size can vary greatly. Excuse me, from very small, almost invisible nodules to very large masses that can fill and distort the pelvis. So, this picture is taken from the laboratory. So, ito yung makikita nyo kapag tinignan nyo yung gross morphology ni leiomyoma sa lab. And then, under the microscope, we will see bundles of smooth muscle cells arranged in an interlacing pattern. And it is often surrounded by a pseudocapsule and is supported by collagen-rich stroma. So, yung picture sa side, yan din yung kuha sa lab under the microscope. And eto, ayan, the one on the left is LPO and the one on the right is HPO. So, ma-appreciate niyo siya sa, excuse me, sa LPO, ayan, yung tinatawag natin na smooth muscle cells na may interlacing pattern. And then sa HPO, ayan nakikita niyo yung mga lines nila, yung pattern nila na nag-interlace sila sa isa't isa. Ayan. And then for the clinical presentation, ito yung mga symptoms na na-experience ng patient natin with leiomyoma. They may have pelvic or back pain and suprapubic comfort, which is due to the pressure from the enlarged uterus. Actually, I wasn't able to put this here, but they may have abnormal uterine bleeding. It's here pala. Especially menorrhagia or heavy menstrual bleeding. And then abdominal mass, which may be felt in larger fibroids. And then infertility, as said earlier, since the tumors may interfere with implantation or distort the uterine cavity. And this image was taken from the internet. And lastly, for the treatment of the patient, its management depends on the severity of symptoms, the size of the fibroid, and whether the woman still wants to have children or they still want to be fertile. So, medical treatments include GnRH agonists, which downregulates the pituitary receptors to reduce estrogen and progesterone, which reduces estrogen production. Since sabi nga kanina, hormone dependent din si leiomyoma. We also have GnRH antagonists, which directly suppress LH and FSH, leading to lower estrogen, and progestins, which suppress endometrial proliferation and help control bleeding. And lastly, for the surgical treatment, this is considered when the symptoms are severe or medical therapy is not effective. And the main option is myomectomy, which removes the fibroid while preserving the uterus. And this can be done laparoscopically, hysterectomy, or through an open procedure, depending on the size and the location of the tumor. So that's it for leiomyoma of the uterus. Thank you.
Pleomorphic adenoma of the parotid gland. So we are given a case of a 40-year-old female consulted at the OPD clinic due to a 5 centimeter painless, slow-growing left infraauricular mass, which was first noticed by the patient 3 years ago. An operation was performed to remove the mass. So for the etiology of pleomorphic adenoma, it remains unknown and may be influenced by genetic and cellular origin from a combination of ductal epithelial cells and myoepithelial cells within the salivary gland, which is responsible for its myxoid appearance. Genetic rearrangements in chromosome 8 in the long arm of region 1 band 2 and chromosome 12 in the long arm of region 5, which encodes for genes PLAG1 and HMGA2. Others may include environmental and lifestyle factors, which are such as exposure to radiation, chemical exposure, which are mainly occupational, such as rubber manufacturing, asbestos mining, and plumbing. It may also be influenced by diet and lifestyle, such as smoking and alcohol abuse. Other factors include age and gender, which occurs between ages of 30 to 60 and are more common in females than males, with a ratio of 2:1. It may also be influenced by hormonal influences because of a higher incidence in women, and infectious agents, which are possibly linked to certain viruses, such as your oncogenic simian virus SV40. So moving on to the pathogenesis, first it starts with the genetic mutations in the chromosomal arrangements, as mentioned earlier, which results to oncogene activation, which leads to a monoclonal neoplastic transformation of the ductal and myoepithelial cells, which then leads to clonal expansion of neoplastic cells into divergent differentiation and ultimately to formation of the pleomorphic adenoma. So the gross findings for this specimen is first, it has a rounded, well demarcated gray white glistening expansile mass. So it's gray white and glistening because of the chondromyxoid matrix, and the encapsulation of the tumor allows for surgical removal within a clearer margin. So for the microscopic findings, we will find epithelial cells, as we see over here, in the chondromyxoid stroma and mesenchymal cells. So the pleomorphic adenoma is a mixed tumor that has epithelial components dispersed throughout the fibromyxoid stroma that sometimes harbors islands of cartilage or bone, which gives its biphasic appearance. So these are just some pictures which we can also appreciate the epithelial cells and mesenchymal cells found in your pleomorphic adenoma. Next, for the clinical features. So your pleomorphic adenoma is a slow-growing, painless, mobile, and discrete mass. It is usually asymptomatic but may have symptoms related to tumor size and location, such as your facial nerve weakness and malignant transformation. Complications may include recurrence because the pleomorphic adenoma may have thin microscopic projections, which, if not completely removed, can cause the tumor to reoccur. And it may also lead to malignant transformation and sometimes complications of surgical treatment, such as facial nerve injury, Frey syndrome, sialocele, numbness, and aesthetic deformity. So that's all for my report. Thank you for listening.
So, good day everyone. Today I will be reporting about desmoid cyst ovary or mature cystic teratoma. So, the case is a 35-year-old newly gravid consulted at the clinic due to gradual abdominal enlargement. Pelvic ultrasound revealed bilateral ovarian masses, and surgery was done. Both masses are cystic and contain yellow sebum-like material mixed with ball of hair. So, mature cystic teratoma or desmoid cyst is the most common benign ovarian germ cell tumor. It arises from a germ cell and contains tissues from all three germ layers. While usually asymptomatic, it may present with abdominal pain or complications like torsion or rupture. So, the etiology is it arises from totipotent ovarian germ cell, meaning they have the ability to develop into any types of tissue, and these tissue cells grow abnormally, and they can form a tumor containing a mix of tissues. And normally, germ cells should mature into ova and only divide after fertilization. In teratomas, the germ cell undergoes abnormal activation on its own, dividing and differentiating without being fertilized. So these abnormal differentiation into somatic tissues from ectoderm, mesoderm, and endoderm, and occurs mostly common in reproductive age women between 20 to 40 years of age and usually benign but rarely undergoes malignant transformation. So in pathogenesis, the origin is a germ cell in the ovary. So it called totipotent, meaning it has a potential to become any type of tissue. So normally, an egg needs to be fertilized to divide. So in this case, the germ cell divides spontaneously without fertilization. And this abnormal activation is called parthenogenesis. So once activated, the germ cell doesn't stop and it starts forming tissues from all three embryonic germ cells or germ layers, such as ectoderm, mesoderm, and endoderm. In ectoderm, we have skin, hair, teeth, and nervous tissue. In mesoderm, muscles, bone, cartilage, and fat. And in endoderm, respiratory and gastrointestinal epithelium. So these tissue arrange abnormally and form a cyst. So the cyst wall is usually lined with squamous epithelium, and the cavity contains keratin, sebum, hair, and sometimes teeth or bone because of the ectodermal predominance. So as the cyst grows, the ovary enlarges and become a palpable adnexal mass. So possible complications are torsion, rupture, and infection. So this slide shows the gross morphology of a mature ovarian teratoma or the desmoid cyst. So cystic nature, mature teratomas are usually cystic ovarian tumors. They are often filled with sebaceous materials, thick or greasy fluid, and keratin debris. So the presence of hair is the hallmark feature is within the cyst cavity. And the hair comes from ectodermal differentiation, and this is where most of the recognizable tissues are found. Heterogeneous content, these tumors may contain skin, fat, bones, cartilage, or even teeth. Um, in the bottom picture, you can see sebaceous material, hair, and solid tissue. And the picture on your left, ovarian resection, mature cystic teratoma with cutaneous adnexal structure and solitary goiter. And the picture on your right, the cyst is with hair and sebaceous material, and several teeth are visible as well. So, microscopically, the squamous epithelium with underlying sebaceous gland and adipose tissue. Next is the clinical manifestations. Usually, patients are asymptomatic and have no symptoms. So, the tumor is usually found accidentally on pelvic ultrasound, CT scan, or during surgery for another condition. This is because the cyst grows slowly and does not immediately affect surrounding organs. Next is abdominal or pelvic mass. Patient may notice gradual abdominal enlargement or feel a lump. On bimanual pelvic examination, a firm mobile adnexal mass may be palpated. Next is abdominal or pelvic pain. And the pain is usually mild and due to stretching of the ovarian capsule or pressure effects. Lastly is menstrual irregularities. It is rare, but some women may experience changes in cycle length or flow due to hormonal influence and mechanical pressures on the reproductive organs. Next is the complications or the clinical presentation. The first is torsion. This is the most common complication. The cyst is heavy and mobile. It twists around its pedicle, cutting off blood supply. Present with sudden severe abdominal pain, nausea, vomiting, and sometimes fever. Next is rupture. So the leakage of sebaceous material into the peritoneal cavity causes intense inflammation known as chemical peritonitis. Next is infection. So the cyst may become secondarily infected by bacteria and present with fever, pelvic pain, adnexal tenderness, and sometimes elevated WBC count. So lastly is the malignant transformation. This is rare, but most often into squamous cell carcinoma arising from ectodermal tissue. So, if suspected, if there is rapid increase in mass size, post-menopausal presentation, or systemic symptoms such as weight loss. And these are my references. Thank you so much for listening.
I'll be discussing the pap smear, including its significance, normal and abnormal cellular findings, specimen collection, and interpretation. To start, Papa Nicolau test or pap smear is a screening tool that allows us to examine cervical and vaginal epithelial cells to detect normal patterns, hormonal influences, infections, and precancerous or cancerous changes. According to Robbins' Basic Pathology, the pap smear is essential in preventive medicine because it enables early detection of cervical intraepithelial neoplasia or CIN, particularly in the transformation zone before it progresses to invasive carcinoma. Moreover, it provides insight into hormonal status and can reveal infections that might affect cytological interpretation. Now let's talk about the significance of pap smear. This test is a critical method to reduce both incidence and mortality of cervical cancer. Early detection of precancerous lesions allows timely intervention, which significantly improves outcomes. The CDC highlights that routine pap testing, particularly when paired with HPV DNA testing, is the most effective strategy for cervical cancer prevention, especially in women over 30. Similarly, the WHO emphasizes cytology based screening as a public health measure, particularly in regions with high HPV prevalence. Aside from cancer detection, the pap smear can provide clues about hormonal influences and detect infections caused by organisms like Trichomonas vaginalis, Candida albicans, and herpes simplex virus, which may alter cytology. Next, let's discuss specimen collection. Accurate results rely on proper sampling of the transformation zone where most cervical lesions arise. There are two main methods. First is the conventional smear. Cells are collected using a spatula or cervical brush and immediately smeared onto a glass slide, which is then fixed promptly to preserve morphology. This method is simple and widely used, although blood, mucus, or inflammatory cells can sometimes obscure the sample. Second is liquid-based cytology. Here, the collected cells are rinsed or suspended into a vial containing a preservative solution. This improves cell preservation, reduces debris, and produces a more uniform and representative sample, improving accuracy. In both methods, it's important to avoid contamination with blood, lubricants, or vaginal secretions, and to ensure that both squamous and endocervical cells are adequately sampled. For pap smear interpretation, results are assessed based on cell morphology, sample adequacy, and degree of atypia, as outlined in the Bethesda system. Negative results indicate no intraepithelial lesion or malignancy, while epithelial cell abnormalities are reported according to categories I just described. Proper reporting should note sample adequacy, presence of endocervical cells, and any obscuring factors. And HPV testing is recommended for women over 30 or as follow-up for certain abnormal results. Now moving on to normal cellular findings. Superficial squamous cells originate from the outermost layer of the squamous epithelium. They are large polygonal flat cells with abundant transparent cytoplasm and small, condensed nuclei, and are predominant during proliferative estrogen dominant phase. Intermediate squamous cells come from the middle layers. They are larger than parabasal cells with round to oval vesicular nuclei and cytoplasm that stains blue or green. They are most commonly seen in progesterone dominant phases, such as luteal phase or pregnancy. Parabasal cells are small cells from the basal and parabasal layers with relatively large nuclei and scant cytoplasm. These appear in low estrogen states such as prepubertal, postpartum, or postmenopausal women. Endocervical columnar cells line the endocervical canal. They are tall, columnar cells with basal nuclei, often forming sheets or palisades. Their presence confirms that the transformation zone has been adequately sampled. Moving on to the abnormal cellular findings, which are categorized using Bethesda system. Atypical squamous cells, or ASC, show mild nuclear enlargement, slight hyperchromasia, and irregular nuclear contours. ASC-US indicates undetermined significance, while ASCH suggests that high-grade lesions cannot be excluded. Usually, these require HPV testing or repeat cytology. Low-grade intraepithelial lesions show enlarged, hyperchromatic nuclei with perinuclear halos known as coilocytosis. LSIL corresponds to CIN1, often HPV-related, and may regress spontaneously but still requires monitoring. High-grade squamous intraepithelial lesions, or HSIL, include cells with high nuclear to cytoplasmic ratios, coarse chromatin, and hyperchromatic nuclei, corresponding to CIN2 to 3. These have a high risk of progressing to invasive carcinoma and need immediate evaluation. And attached here are the resources used in this presentation.
Hello, good day. I'm Daniel Jonathan Elpangan, and I will be reporting the rectal adenoma. What is rectal adenoma? A rectal adenoma is defined as a benign growth or polyp that forms on the inner lining of the rectum. Although it is benign, it is considered a precancerous lesion because it has the potential to develop into a rectal cancer over time. Etiology. The cause and risk factor for rectal adenoma include age, which is will be a significantly increased after the age of 50. Second is diet, which a high diet with red meat, animal fat, and low in fiber is a major risk factor. And of course, lifestyle. the obesity, smoking, and a sedentary lifestyle and excessive alcohol consumption increases the risk. Genetic predisposition. Familial adenomatous polyposis, which is known as FAP, an inherited disorder resulting from a mutation in APC gene leading to thousands of colonic adenomatous and a nearly 100% risk of cancer if not treated. Lynch syndrome or HNPCC. It is a inherited condition that elevates the risk of multiple cancer, including the colorectal cancer. The key gene mutation. First is APC gene mutation initiates the adenoma formation. Second is cross mutation promotes growth and proliferations. Third is P53 mutation is associated with malignant transformation. Next is the pathogenesis. The development of rectal adenoma follows a multi-step process involving genetic mutation. First is initiation or first hit. This is where inactivation of APC gene influenced by genetic predisposition or family history, lifestyle, and age leads to uncontrolled proliferation of epithelial cell and polyformation. Second is adenoma formation or second hit. This is the next stage that involves further genetic change that advance the adenoma. Third is advanced adenoma, which is where cross genes mutation causes excessive cell growth and inhibits apoptosis or programmed cell death. Fourth is high-grade dysplasia, which is where P53 mutation results in the loss of tumor suppressor gene, leading to impaired cellular function. Next is gross morphology. On a macroscopic level, rectal adenoma or polypoid lesion that arises from the rectal mucosa. First is shape, where they can be peduncle or sessile in shape. Next is size. They are usually less than 1 cm. In texture, the surface is typically smooth in tubular adenomas and has a velvety or cauliflower-like appearance in villous adenomas. Microscopic morphology. Under a microscope, rectal adenoma exhibits several distinct features. First is closely packed or elongated tubular glands with some mild branching and crowding. Second is a decrease in goblet cell and reduced mucin production, because we all know that goblet cell is the primary responsible for the mucin production. Third is the presence of dysplastic columnar cell with cytoplasm that is often eosinophilic. So here is the clinical features. Rectal adenomas are often asymptomatic and discovered during the routine colonoscopy. When symptoms are present, they can include occult gastrointestinal bleeding leading to iron deficiency anemia, changes in bowel habits, and rectal bleeding. The malignant potential is stronger with larger size, villous histology, high-grade dysplasia, and a positive family history. And lastly, for the treatment or medication, the management strategy for rectal adenoma includes polypectomy, which is where we remove the polyp. And second is histopathologic evaluation, which is the microscopic examination of the removed tissue. Third is a surveillance colonoscopy, which is a regular follow-up screening. And of course, the lifestyle modification. And that's it. Thank you. And this is my references. Good day. Thank you.